To just review
I'll do that,
what
or
normal
I'll
ranges
send
are.
you your breath.
So, you know, heart rate for an adult normally between
Otherwise,
60
I
and
have to go
100.
like this and
Blood
kinda-
pressure is a systolic, can run
Oh,
from,
okay, go
it
under
depends
and
really on
kinda
age
push them up so
and
that
all their medical
I can kinda
conditions,
get
and it can vary quite a bit, but
Then you're not
it's
really
generally
touching
between
their-
110 and 145 are considered
Yeah.
a normal systolic blood pressure depending on patient's age. And
I
diastolic,
go
somewhere between
low.
60 and 80-ish are considered.
I go low, yep, and then as I
Respiratory
tighten it,
rates,
I'll
you
kind
know,
of.
12 to 20.
Yep.
If someone's breathing too
Or I'll
fast
just
and too
tell them,
shallow, we don't want
This
that.
might pinch, you might wanna
Not
lift.
breathing
They
much
kinda,
at all, we
they
don't
know
want
what
that
you
either.
mean. Yeah, no, I
So
know.
it's important to, you know, notice how often they're breathing, and you do need to
Yeah,
come in
and if
a
you
lot of
have-
times, cause even if
I
they're
like
on a
it to be
telemonitor
here
or
because my hand is more.
whatever, that,
leverage.
lead
Then
doesn't
when I'm up
count
here,
accurately
if
a lot of
something would
times, like
happen,
it'll say
it's
someone's
across their
apneic
chest.
and they have a
Yep.
saturation.
So I always go around.
You know, so just take a second and actually count it and pay attention to, do they look like they're taking a full breath or not? Are they panting, are they wheezing, are they struggling?
And it's more
Those are things that you
uncomfortable for
wanna
them
let the
when
nurse
they're trying to
know.
move their arms and do stuff
However,
across their chest.
If you do get an odd blood pressure, you need to just go ahead and confirm that. Like, retake it, make sure your blood pressure cuff is in the right
Yeah,
spot.
yeah.
Try it on the other arm. Occasionally, it'll read differently depending on how their circulatory system is functioning. And make sure you have the right size cuff. Because too big of a cuff will read a little low, and too small of a cuff will read a little high. A lot of times we'll have short, wide people, so their arms are wide, but they're not long. So you wouldn't wanna put this on one of those patients. You don't want the blood pressure cuff over their elbow at all. That's what the adult bong is for. It's the most commonly used one, I feel. If for some reason there's just no way to get a blood pressure cuff on their bicep to fit well, like it just won't work, or they got too many lines going, or whatever. And you have to, you can use a small cuff and put it on their forearm, you can also put one on the calf, but neither of those readings are as accurate as the arm, the bicep one, so that's always what we aim for. Okay, so any questions about vitals? I mean, how often do you take vitals for a tele patient? Yep, every 4 hours, yep. What about a general medical patient? Unless it's their first 24 hours, yep, then it's every 4 for the first 24, cause you never know, they might turn a corner in a bad direction. And then our progressive care patients, how often are those? Every 2, yep. And same with ICU, it's a minimum of every 2. A lot of times the nurses will do it more frequently, depending on what kind of drips we're running or why they're in ICU status. All right, okay, so eyes and nose, really important. It's been a problem everywhere in the hospital to get these done accurately and consistently. But they do give a lot of information that the doctors utilize in order to drive the treatment plan for the patient. It lets us know, obviously, their fluid balance, but the fluid balance will tell us like metabolic function, organ function, maybe how medications are actually affecting the patient. Their eyes and nose might affect their vital signs. If they're overloaded, they could have high blood pressure. If they're dehydrated, could be low and tachycardic. Like, all these things go together. So it's important to be accurate with it. Personally, I think everybody's eyes and nose should be calculated all the time, whether there's an order or not. It can sometimes be an early warning sign. Like, you know, this guy hasn't peed all day. That's weird. Or, yeah, they're not drinking at all. You know, these things could maybe be a flag to let us know, like, we need to look at some more things. So if it's a strict INO order, that really means to tally things every 2 hours. Obviously you can't do that if people are independent, whatever, but if it's a true ICU patient, like on a ventilator, the nurses are gonna be tallying all their IV stuff and everything every 2 hours. So if they're independent and they're strict eyes and nose, and you just need to get it in there as quickly as you can and be accurate about it. So the graduated cylinder is the most accurate measuring device that we have. This one is pretty accurate as well. We'll use this one for like drains, So any liquid that comes out of a patient, whether it's from a wound drain, it's an NG hooked up to suction, obviously urine, liquid stool, vomit, blood, anything liquid that comes out of the patient needs to be measured. So we will try to do our best to get patients to get their liquid stool or urine into one of these things if they don't have a Foley. And then you need to remember that anything that melts in your mouth, any foods that melt in your mouth count as liquids too. So like Jell-O, ice cream, sherbet, that Italian ice stuff, anything that turns liquid needs to be measured. And so if they are not strict ISO, it's just INO order, then it needs to be tallied by the end of the shift, so an hour before the 8-hour shift ends, so 6, 2, and 10. They need to be tallied, Foley's emptied, like everything added up, at a minimum. Now the Foley's, if they have a Foley with a urometer, and they have strict INO orders, just kind of check in with the nurse, because chances are they're measuring what's in that urometer every 2 hours and then tipping it back, and then you empty the whole bag at the end of the shift, so you're not opening and closing this multiple times, you know, giving it more chance to have germs in there. But you don't want to make sure that you're not double charting, or you don't then measure everything in the bag at the end of the shift after it's been charted every 2 hours, you know, things like that. Just check in with the nurse if they're doing it or if they want you to do it or whatever. So make sure you're on the same page. If it's a Foley bag without a urometer, you have to measure it with a graduate, because I don't even know why they bother with these numbers. They're not accurate at all. So that is about all for that. Any questions on I's and O's or? Okay. The only other thing just want to kind of review is occasionally we'll have patients on a calorie count because we're concerned about their caloric intake. If you have one of those patients, just grab the little ticket off their tray and then put a percentage next to each thing of how much they ate of it. And then, like, you know, they had half their apple crisp, just put 50% next to that. If they ate it, you know, if they didn't eat any of it, 0. And then there should be a little envelope outside their door to put it in, and the dietitian will calculate all of that. They just need these percentages from us. You're charting, there's nowhere to really chart that, but you would still do the same meal charting that you would, you know, tallying up the percentage of the whole meal for a chart. This gets missed a lot too. Like, people will collect trays and didn't add up, and then we don't know. And they need to know which things they're eating, because that's gonna affect their calculations. Like, are they getting enough protein, or are they only eating the pudding, you know? So these are all really important things that, you know, give a overall picture of how a patient's doing, and it's important info, and can definitely raise flags if things are changing quickly. So that's all I got.